some anesthesiologists in Utah Valley Regional Medical Center, from what I understand, they don't use local. They think that the pain of the local needle and the burn of the local is just as bad as the epidural needle going in.
Oh my gosh. I could see for a small needle, maybe.
I don't think that's true. This would hurt like a mother.
It's a big one.
Plus you have to fish with
Going
it.
in
So
deep.
use your local, okay? Use your local. Another one you're gonna have is gonna be some normal saline, probably in a clear blue bottle. That's what you're gonna use if you're doing your loss of resistance technique and you like to have fluid. Remember we talked about this before. Some providers like to have all fluid, some like to have all air, and some will have fluid and a little bit of an air bubble in it. I was an all fluid guy, you are
All air.
all air guy.
But I use my NS to lubricate my syringe.
Okay, so he will put some in your
And I'll show you that in a while. Yeah.
glass syringe, right? This is what we use to find the epidural space, loss resistance, because it's very slippery. Compare that syringe with your 10 cc syringe. That is a whole nother world. So this is why we use the loss of resistance syringe when we're doing your loss of resistance technique. And then last but not least, as far as fluid, is going to be your test dose. Okay, clear bottle, red writing, lidocaine, epi. We're going to use this when the epidural is, you think, in the right spot, and we're going to go ahead and give that test dose. Other than that, you're going to have multiple needles for local. You may have a filter, and then you're going to have some type of a connecting device. What do you guys have in yours?
Same one.
Okay, so we have the same kit. So some type of connecting device to put on the edge of your epidural catheter, so you can then attach your syringe, give your intermittent boluses, and or connect it to your pump through your lure lock tip. Okay? Any questions about the kit itself? Filter. So you'll put that on. You'll put that on. And then some people don't use it.
This thing would hurt so bad.
Put
It's
that
not
on
even
there,
sharp.
and you put your catheter on here.
Is this supposed to be your test dose, Lycaine?
That is your test dose,
How do
the
you
red
do that?
one. What's that? Take that off. Okay, that's your test dose. That is to, when you're done putting it in, Ted will show you in the lab. Everybody kind of tapes it differently, but usually when you're done, you'll put a little loop on it, and this is what you use to attach it to.
How do you attach this? You slide that yellow.
Yeah. I haven't used this before, we'll practice, but I think you put it in that hole and then slide it forward like that. Okay? Yeah, it's good. And the question is, some of them you can and can't, yeah, you can undo it too. So just slide it up, once your catheter is in that little, the teeny hole, put it all the way in, and then slide your yellow piece up and it'll lock it in place.
And then these are all filters, right?
Looks like they certainly, yep, okay. All right, so, indications for epidural placement. When do we do epidurals? Let's just kind of review this really quick before we get to the hands-on. Laboring mother is the one that you're going to be doing this the absolute most. Laboring parturient. Okay? When else? Gosh, it's hot in here. When else do we do epidurals?
Thoracic surgeries?
Yeah.
Okay, what else?
Some ortho, like
Yeah.
peds, like hip.
Okay, a lot of ortho stuff,
Dysplastia.
right?
Big belly.
Yep, big belly cases are great, okay? So whenever you are worried or want to take care of your patient, and it's going to be, if you think about it, if you're putting an epidural in, these are going to be the cases where they're probably going to be staying at least 24 hours, right? You're going to want to get pain control. But we are going to be doing epidurals most of the time. Most of the time for laboring moms. So when we're doing your test, let's just go down that road, because that's the one we're doing most often. Okay, so pain control for parturient. What are some things that you would want to tell your mom are risk factors of an epidural placement? Okay?
Not working.
Infection doesn't work. Bleeding.
Hematoma.
Headache.
Okay, hematoma, headache. Okay, those are all good. You can put them in whatever order that you want. The one that I would probably get more specific on would be death. Yes, I would focus primarily on death.
We need to
I
sit
would
down
say,
and
I know
talk.
that you're here for an elective procedure. There's a good chance that with a catheter you are going to die.
Well, that's on the list,
It
your
is on the
baby.
list.
You and
You and your baby. Your
Whole
husband or
family's gone.
Significant other is gonna leave all by himself. So would you like me to put in your epidural catheter now? And shake a lot
I
of
like how it's right
Let's
there.
go
I was
to-
reading through, I was like, oh, you just slide that in there, huh?
And death. You gotta cough when you say that one, Sarah. So put that in any order you want. If you want to get into more specifics with having a post-dural punctural headache, right? I think I would tell my patients that there was, what is the percentage now? Less than 3%?
For what?
For post-PDA?
No, it's less than 1%.
So I guess for me it was less than
It
3.
depends.
You know,
For
that
you
was less than
guys,
one.
it's probably
For me it was like a 50-50. I said, there's a half chance that you guys are gonna get a headache with this epidural catheter. But then you take, it's a bad headache, you'll know it, it can be a couple hours or a couple days after. And I actually want you to talk about, the reason I'm going more specific is on the video, I want you guys to talk specifically about the post-dural punctural headache. It might not be per se in the rubric, but when you're talking to the patient, throw that in there just because it's good practice for you guys to be talking about that. And then talk about the treatment of a PDA. What is the treatment for a post-dural punctural headache?
Lean flat.
Blood patch, okay?
Okay.
So that there's two things. Well, there's
Prevent.
two paths. There's conservative and then there's more aggressive. What's conservative?
Fluids,
Okay,
caffeine.
fluids, caffeine,
laying
benzoate, how
down,
much?
Rest.
I can't remember.
Caffeine? I think it's 1,000 milligrams. It's a crap ton.
Jabrina?
So it's like multiple Rockstar drinks that
Damn,
we
man.
guys drink,
Get
like
freaking
4 or
go.
5 of those bad boys. So it's IV caffeine benzoate is what it is. So that's kind of the conservative approach. Maybe it'll work, maybe it won't. The more aggressive approach is
Blood patch.
blood patch. So explain the blood patch. How does that work?
Start IV.
Take blood.
Start an IV,
Take blood, put blood.
put it
Yeah.
Okay.
where the
Epidural.
puncture was.
So then-
Start at.
Just draw it out sterilely. You need to start the IV. Just get a
You can
20
use an
cc,
IV.
30 cc, yeah, and draw it out sterilely. You can do it, you can have your nurse do it, as long as he or she knows what they're doing and they can give it to you sterilely, right? And then you put in another epidural needle, yes, above, below. The prior, do you want to go to the prior site?
No.
Okay, you want to go above or below?
But
Isn't it below because it goes
It
so
goes
flat?
out.
Okay? Below is what I've always been taught. Now, given you that the bevel of the needle is up, but that clot, as that blood goes in there, it will probably settle down, especially while they're sitting up at first, if you're doing it in the sitting position, right? So you put in how much until when?
So they feel the pressure.
Okay, until they feel pressure. And they've got to be like, it's got to be a lot of pressure. They say I'm feeling a bit of pressure. I'm like, that's good. Let me know when it really starts to feel pressure.
Because they'll feel pressure right off the bat because it can make your muscles spasm and cramp.
So last night they're really hurting. I'm trying to get that whole thing in. How much do you give?
Isn't it a lot?
I think the book says 20. I've given up to 30.
Oh, wow.
I filled up that epidural space before. You can see the clot filling in the back of their eyes a little bit. Once I see it in the whites of their eyes, then I know you've got enough of a blood clot.
We
So we're
might
good to
be
go.
getting there.
Pull out the needle, because it's just a one-shot deal right now when you're doing a blood patch. It's a one-shot deal. Pull it out, and then what? Jumping jacks,
laying down.
lay it down. For how long? At least?
30 minutes.
At least 1 hour. Okay, longer the better. Think about this, a lot of times these guys are coming in, if it's a lady that delivered, right, they're home now. Because these headaches sometimes don't exhibit for days after. So they may be coming in kind of an outpatient thing. You may be in same day, you may be in the ER, depending on where your facility wants to put them. So you're laying down for at least an hour, but they're always anxious to get home because they've got a new baby, they want to get out of there. The longer the better. Did you have the lady that got in the shower? Did I tell you that already? Yeah, so explain those kind of things. Yes, we're letting you go home after an hour, but go home and take it easy. Don't walk around, just go to the bathroom and come back for the rest of the day, just chill.
Even though you feel better, 'cause
Yes.
you will.
Yeah, 'cause the headache, if it's working, the headache goes away while they're sitting there, as you're filling up that space. Let's physiologically, what has happened as you're doing that blood patch?
Stopping the leak.
Okay, so you're in theory stopping the leak. Okay, so you're putting a clot in the epidural space, which then increases cerebral pressure because it's pushing up against the intrathecal space, right? which then, I mean, the headache is from what?
So dragging
Decreases
the,
CSF.
Right, the meninges are getting pulled, right? You've got that drag on your tentorium. So if you're increasing that pressure to the CSF, that brain is literally like floating again. So they're not getting that stretch and that pain. That's where it's coming from. So that's the goal. That's why I try to get as much as possible to increase that pressure as much as possible, so they won't have a headache. What are the chances of it working?
90%.
90%.
What's that?
90% cure
I
rate.
thought it was higher. Is that what the book was saying?
90.
The book said 90? I've always been taught higher than that, like
And then,
95 plus.
The second, like,
What's the second one?
like-
So the first one doesn't work, the second one, at
Yeah,
least
yeah.
95,
Yeah.
right? So
No,
you've
sorry,
got-
an epidural blood pressure is considered the definitive treatment with a greater than 90% cure rate.
Okay, I always tell like 95 to 98%.
that is greater than
Okay,
90.
that is greater than 90. That is the definition of greater than 90. So you can take that 2 to 5% that it didn't work and do a subsequent one. Now you've got 5% that didn't work, and now you're doing another one that's 95-ish% of that 5% that worked. So after 2, it's almost a guarantee. Not always, but it's almost a guarantee the second one is going to work.
And you just use the epidural needle.
Just use the epidural needle, no catheter on this one. Yep, find the epidural space, and everybody's got a different routine. Well, but it's not as deep, right? Right, it's in the epidural space. So everybody's got their own routine for this. I would have everything ready for the blood to be drawn. I would go back, because you did think about this again, right? If you've got somebody who's got a wet tap, there's a good chance this was a difficult placement, because they tapped them, or somebody tapped it. So putting another one back in might not be as easy as doing the patient. So get everything ready. Don't have them draw the blood yet. I would find the spot. Then I would have that, while I'm holding the needle, have that individual sterilely draw the blood, hand me the syringe, and then I slowly start to inject. Okay? But everybody's got their own, some people do their own blood, did you do your own blood? I think that's painful. Okay. So indications, risks, contraindications. When would you not want to do one? Sorry?
Coagulopathy.
Okay, some type of coagulopathy. And again, these are things I want you to just kind of rattle up on the video.
Refusal.
Oh, by the way,
Infection.
can you all do it on YouTube, please? It's an immediate upload, and I can 2 times your speed. Not that I don't want to hear you at normal tones.
We do it too.
Okay, good. Because we know what we're looking for. You can say it as fast as you want. We're going to catch it, and I can still watch your hands. So YouTube and 2 times the speed. Okay. So
Notice I got my grade a lot quicker this time.
that's right. Coagulopathy. What else?
Infection.
Infection. You never put any needle anywhere through an infected spot. Okay. Anything else?
Refusal.
Sorry.
Refusal.
Okay, that's number 1.
That's the
Right?
only
That's
main
and
one,
that's,
right?
by all means, if you want to have this down, that is, good for you. I'm here for you when you need it. Okay, and there are some kind of a back side note. Traditionally there were some OBs that would be like, okay, you can't have an epidural until you're at least 5, 6, 7 centimeters dilated, because they said that it would always slow down the labor. So they wouldn't call you until they're at that point. Now they're coming in, and it's like they want you to go to their house, put the epidural in before they even get in the car to come to the hospital, because they don't want to sit in the car, right? They want it right when they get there, and that's just kind of how it is now. So just be prepared. You'll be going in, and I think it's easier to put in a parturient who is laboring, because they're having pain. So what you're doing back there, they don't really care much about, versus somebody who's coming in off the street, they don't have any contractions yet. They're focused on everything back to what you're doing.
Except for they sit still.
What's that?
Except for they
They
sit
do
still.
sit still a little bit better, most of them, yeah. Okay, let's see. Indications, contraindications, bad things that can happen. What else is on the rubric? Is that it? As far as talking to your patient? Alternatives, thank you. Alternatives, give them a tongue blade, like that. What else?
Water.
Water birth.
Hypnobirthing. Yeah.
Oh, a water bird. I didn't hear the birth part. I just heard water. Yeah, have some water.
Yeah.
That's
Have
gonna
a
help
drink,
contraction.
sure.
Come on. Ice water. Okay, so then you can go without, and you can do IV pain medicine, but it's only gonna help for a little bit. And I always, if I had a mom that was a little bit anxious about the epidural, your calming influence will usually get them to change their mind. But if they were thinking they were gonna do IV, I would usually say something on the lines of, if we give you medicine in her IV for pain, that goes right to the baby. So the epidural stays kind of in your central area, and it doesn't go to the baby, or it doesn't go to the baby very much, if anything does. That usually is a tipping point for most moms. They don't want their baby to be narcotized when they deliver, so they will go with the epidural if they were the baby.
Do IV meds work like well for labor?
They work okay at the beginning, I found, like at the beginnings of labor.
Oh,
But
like
once
early
they get,
on.
yeah, once they get to the end,
It's not.
no. I don't think so. I've never, maybe some people.
I've never
who
heard anybody
delivered,
doing IV
What was the
meds.
question?
General
IV.
anesthesia is pretty much the only thing that works.
Like
for
Norse.
It doesn't hurt that long, and we would.
If you don't have an epidural.
Oh, really? You just wouldn't after a certain point.
What was your rule?
We didn't give fentanyl after they were 8 centimeters.
Yeah, I was gonna say, cause if you give it
And we
early
call
enough,
it
it'll
maybe
wear
then.
off in time, right? And you won't have the complication associated with the narcotized baby.
I don't know if
So-
anybody in here's delivered. Not that issue. I mean, I've gone to the bathroom really big a couple times, but.
It's about the same.
It's gotta be close. Ted will call.
I would love a
Ted will get
narcotized baby for,
the,
like, the
sometimes
first,
he's
like,
got a
3
little,
months.
incubator in his house. Ted will go over to those kids and do that.
Keep it warm.
He names them. Okay. It's hot in here, isn't it? All right, questions on your kit?
I have a random question.
Okay.
Did you guys ever learn to do pudendal blocks?
No.
No, no.
Nope.
I had a
Typically
few
OBs,
OBs that didn't, but I didn't
Yeah,
know.
and it's usually the older docs. Kind of the
Aren't they
newer
coming back?
generations didn't do it as much.
So.
Are they coming back?
Yeah.
Oh, really?
Yeah, the
Yeah.
docs that did them a lot.
Why did they go away?
Epidurals work really well.
Yeah.
Oh, just because
Sometimes you get a
epidurals work
spotty
well.
block.
And you're doing it.
And the docs didn't wanna come in because they're at home.
Oh.
So then you don't fight.
I have a question. Do you talk to them in the risk factors? Do you talk to them about them slipping?
Yeah, a little bit.
Slipping?
Yeah, I've had an epidural that slipped, and I never had a CRNA talk to me about how they can slip. Like where they come out of the epidural space.
Oh, yeah.
Yeah.
Is that like a risk factor we talk to them about?
Yeah, you can throw that in. Everybody's got their own repertoire, so you can put that in there.
That would fall under not working, it doesn't work.
Throw that right
A
after.
one-sided block. is fine.
Right after death.
death.
It doesn't.
You
that
may
doesn't-
die,
minutes.
or it may not work.
And are your patients getting up and walking after this goes in? That is something you need to tell them too. Once this is in, you're in bed now, right? Once it starts work, they're getting a catheter. They're not going to the bathroom anymore. They're just chilling until.
They
You
might go
get,
back.
you get people that ask you for a walking epidural. Can we do a walking epidural? Because they've been on the internet. reading.
The mom
It doesn't
forums.
really work out.
Yeah, it's too risky. Too risky. Okay, let's go next door.